I think you were on vacation.
But what I mean, like vacations away.
Yeah.
Okay, are we ready? Because we've been doing this. We are 20 minutes late. Okay, so today we are going to talk about paroxysmal sympathetic hyperactivity, or PSH. And Stephen, because you are in the neural ICU this month, can you let's just pretend that you are called with this console from the surgical ICU. Can you read us what is happening?
Yeah, a 23-year-old man admitted 1 week ago with severe TBI, admission GCS 4T after being hit by a car while riding his bike without a helmet, consulted to neurology to rule out seizures. Nurse stated that he had intermittent episodes of tachycardia, hypertension, diaphoresis, tachypnea, extensive posturing, and vent asynchrony every time she suctioned him. Episodes subsided when she increased the fentanyl drip.
And then on the right side, you can see he had a traumatic left like frontotemporal subdural hematoma, status post craniotomy, evacuation. And I think like he's kind of tilted, so you cannot see the other lateral horn. I'm sorry, anterior horn. And he has IVH, some contusions with cerebral edema. So you know this guy has severe TBI, right? His CS is 4, he's intubated, and there is something that is kind of paroxysmal and having all these episodes together. And actually she mentioned, every time this happens, I just increase the fentanyl drip and the symptoms seems to improve or subside. So at this point, what do you think about seizures and being treated with fentanyl drip? When the nurse tells, because your nurse is gonna tell you the most reliable information. She's bedside, she's always with your patient. So doesn't that sound weird, right? Right, fentanyl drip is analgesia. It's not really a benzodiazepine, it's not an anti-epileptic drug, has nothing, no mechanisms known to treat seizures. And so at this point you are suspicious as well, but you decide to do an EEG. You never know, this patient is comatose, maybe he's having seizures. So obviously, because we are talking about paroxysmal sympathetic hyperactivity, that's what the patient has, and we will go back to the patient. But I think this is a very important topic because it's under-recognized and it's confusing, especially because people call it like 30 different names, and we still don't know or understand the clear pathophysiology and of why this happens. So since the 1920s, and one of the neurosurgeons started describing this type of syndrome and phenomenon in this subset of patients after severe brain injury. And some people call them brainstem attack, central dysregulation, acute midbrain syndrome, tonic decerebrate spasm, tonic cerebellar fits, and sympathoadrenal response, autonomic storming, which I think that was actually one of the most famous pseudonyms. Thank you. And dysautonomia, paroxysmal hyperthermic autonomic dysregulation, which sounds kind of similar to the PSH. And it was called even diencephalic seizures. And this was, and the people that observed this type of phenomenon tried to correlate what was happening to the patient anatomically and the brain injury that was related to all the symptoms and tried to put names that will go together. So in Dr. Pinfield, since 1929, he noticed these episodes and he kind of tried to describe them by saying that it's a dissociation between the sympathetic and the parasympathetic and autonomic nervous system. And basically the dissociation is at such point that only the sympathetic symptoms are predominant, right? And we see tachycardia, hypertension, tachypnea, fever, pupillary dilatation, decreased level of consciousness, diaphoresis, and ventilator desynchrony, which is what we saw in that consult that we had from the surgical ICU. And most of the time they are paroxysmal and they're cycles, and they have any type of trigger events. Like our patient, the nurse noticed every time she suctioned him. But there are other patients that even by being touched or being repositioned, they can have these paroxysmal events of at least 2 to 3 of these symptoms together and for a couple of minutes, or that subsides after you do treatment for pain or treatment for the sympathetic storming that we are gonna describe in detail and at the end of the presentation. So the most formal definition was done in 2014, and you will see at the end the references. And there were like 3 to 4 different academic centers that studied the phenomenon on these patients and basically tried to come with a nomenclature, not to only identify it, but also classify it as mild, moderate, and severe, depending on the symptoms, and also try to find what are the effective treatments, depending on which symptoms were the most predominant on each patient. And they basically said that paroxysmal sympathetic hyperactivity is a syndrome that has been recognized in this subgroup of survivors that has, I would say, moderate to severe brain injury, because we see it also on moderate brain injury. And you have simultaneous paroxysmal transient increases in sympathetic features like heart rate, blood pressure, respiratory rate, temperature, and sweating, and motor activity. And usually this involves decelerating posturing.
You have a standard criteria that has to meet this much heart rate or you do?
We are gonna, yes, there is
Use
an
extended
assessment.
duration and
There is an
episodes, yeah.
assessment tool that I am gonna show you, and that they develop with all these effort of making the nomenclature uniform. So this is a diagnosis of exclusion. That means that you have to make sure that your patient is not septic, is not having seizures, so you're always going to do an EEG, and is not having pain or is not withdrawing from alcohol, benzodiazepines, or sometimes they are 1 week on the fentanyl drip at 300, and as soon as you start lowering or they just stop it, they can go into opiate withdrawal. So that's something else that you have to have in the back of the mind. Make sure your patient has imaging showing that doesn't have hydrocephalus, because patients with hydrocephalus can also manifest in these ways. And any increased intracranial pressure, worsening of cerebral edema, and hemorrhagic shock. Obviously, at the beginning, you can be tachycardic and hypertensive, but at the end of the hemorrhagic shock, you will be hypotensive. So, but also, have it in the back of your mind that your patient is not bleeding, especially if you are seeing this phenomenon early, the first 24 to 48 hours, and you have to make sure that you are not confusing this phenomenon with any of the treatable causes for sympathetic symptoms. So this has been described mostly on severe traumatic brain injury patients, and what has been observed in ischemic strokes, especially malignant polo left MCA strokes, and with extensive cerebral edema. Also patients with anoxic brain injury, especially the post-cardiac arrest. Patients can develop sympathetic stormings or paroxysmal sympathetic hyperactivity, and intracerebral hemorrhages, patients with encephalitis, and also patients with subarachnoid hemorrhage secondary to rupture aneurysms. So again, up to 30 to 35% of comatose patients with severe brain injury have been identified to have this paroxysmal sympathetic hyperactivity, and we still think that is underdiagnosed, especially in other type of pathophysiologies for brain injury. That I feel like in traumatic brain injury, most of the people will think about it if your patient is presenting with all these phenomena. But if you're seeing an anoxic brain injury or a subarachnoid hemorrhage, you tend to not think about it so much. And has been reported in the literature as fast as 24 hours after having the brain injury and can last weeks after injury, even years after brain injury. And, and it's important to recognize because we think that these patients may have additional morbidity, that maybe we are perpetuating secondary brain injury. And in neurocritical care, we focus on preventing or trying to treat all these secondary brain injury effects because the primary brain injury already happened, right? You cannot reverse that stroke, you cannot reverse that traumatic brain injury, but you can definitely try to target all this inflammatory cascade that is happening after the primary brain injury and prevent your patient to have worsening of cognitive function and in a long term or even die because is having cardiac damage or is becoming catectic or with severe nutritional deficiencies. And some study has actually inferred that these patients get worse clinical outcomes and they stay in the hospital for longer period of times, and obviously that translates in a higher healthcare related cost. And some neuro rehab studies have suggested that there is no difference on morbidity and mortality in patients that develop sympathetic storming versus patients that doesn't develop it. But they have noticed that the patients with storming will need more psychoactive medications. So why does this happen? We still don't understand it very well. And the most famous theory and kind of intuitive is that you have a disconnection between the higher inhibitory centers in the cortex or in the thalamus and in the upper brainstem, and especially in the midbrain, and where the periaqueductal gray is located, and all those nociceptors are trying to receive the input and the sensory input from your periphery and trying to interpret if they are some nauseous stimuli or non-nauseous stimuli. And so all those inhibitory centers are trying to maintain homeostasis to the response of the autonomic system, trying to promote blood flow and trying to preserve your organs after brain injury, are basically not working. And at that point is when you only have your clinical response that is basically a pure sympathetic reaction. And so, but a lot of people were thinking that when you look at patients' imaging, especially in anoxic brain injury, you couldn't really pinpoint those inhibitory centers to be damaged and not able to inhibit on giving negative feedback to the autonomic system that was coming from the spinal cord. And then you could not really explain the sympathetic hyperactivity by this theory. Does that make sense? Mm-hmm. It's a little bit like, basically they were saying that the higher inhibitory is disconnected from the lower excitatory. And that's when you see all these sympathetic reactions and your abnormal vital signs. And so more people kept studying animals, and this is actually the most accepted theory these days, and is the excitatory inhibitory ratio. And this one just establishes that the inhibitory centers are basically everywhere, or mostly in the thalamus or in the diencephalon and the upper brainstem, specifically in the periaqueductal and gray in the midbrain. And that they are not really not working, they are just not working adequately. That the amount of brain injury that your patient has been through and the amount of stress that your patient is going through secondary to the brain injury is definitely intercepting and affecting that homeostasis that is supposed to happen between the parasympathetic inhibitory input and the sympathetic stim, um, excitatory input. And so we all like this theory more, and that the inhibitory centers definitely don't work. And because this can explain better why some patients that have normal imaging can get this type of sympathetic hyperactivity without having a total disruption between two structures per se. And also this is giving us a suggestion of how should we treat and approach these patients, right? And other type of studies that has been done, and actually I have the reference for this one, I thought that was interesting. They decided to measure the catecholamines and the adrenocortical hormones levels in patients that were storming in comparison with patients that didn't storm, and actually patients that were storming during the storming episodes and in between the phases of storming and per se. And they noticed that even the pathophysiology of your brain injury will make your patient release certain catecholamines more than the other. For example, severe traumatic brain injury was related with more dopamine, epinephrine, norepinephrine, and even ACTH release. And but aneurysmal and subarachnoid hemorrhage had mostly norepinephrine releases. So it's not only that sympathetic hyperactivity per se happens in patients with moderate to severe brain injury, is also the way your patient is going to respond, and the pathophysiology per se is going to be secondary to the brain injury, and how those inhibitory and excitatory mechanisms and feedbacks are damaged in every patient itself. Even in the phases where your patient was storming, in comparison when the patients were not storming, they noticed that there was a difference in all these hormone levels, meaning that they were higher when the patient was having the symptoms versus lower but higher than the patients that didn't have storming, in between the sympathetic storming symptoms. And obviously this means that our patients had an intact hypothalamic pituitary adrenocortical system. So there's nothing to be related with any problem per se. Everything is central. And this is made basically the diagram trying to explain where those inhibitory and centers are located, mostly on the thalamus and in the periaqueductal gray in the upper brainstem or midbrain, and how that try to maintain that homeostasis and that feedback, that if when you get your non-nauseous sensory stimuli, you will come and you provide that information to your brain, and your brain will be able to analyze it and have an appropriate response, right? A normal motor output and a normal sympathetic output. And for someone who has moderate to severe brain injury, basically even a non-nauseous sensory input, it's gonna trigger an a nauseous stimuli response and increasing sympathetic output, increasing motor output, because this feedback and basically regulatory system is not able to maintain that autonomic response and that sensory input under control and being analyzed like it's not nauseous, or if it's nauseous, to try to ameliorate the type of response that your patient is going to have. So basically, when are you going to suspect PSH? And these you're going to find in the assessment form that we are going to discuss, like the likelihood of PSH every time you evaluate your patient. And so most of the time you want multiple clinical features together, at least two of them, like heart rate with blood pressure or heart rate with increased temperature or posturing or even mild sweating. And you're going to be, I will say, more likely to have PSH, or you should suspect PSH more as the most likely and etiology of your patient's symptomatology if you have more than one clinical feature. Not that the patients cannot have only one. Like, for example, we know central fever, and sometimes the patients only get fever, very high fever, temperatures of 40s. But in general, you will feel more comfortable saying, okay, this is storming and this is mostly central fever. We have negative cultures. If the patient has central fever with posturing or central fever with the sweating. And the clinical features are also paroxysmal, intermittent, and they last a couple of minutes. And after the stimuli, they're usually a stimuli or triggered by some sort of and by you even touching your patient. And you see sympathetic stimuli over and even non-nauseous stimuli. And your patient can be normal and during the episodes or in between the episodes, but then you really don't see much parasympathetics and in between the episodes. And the symptoms usually occur more than 3 days in a row, and they persist for several weeks. And they persist even when you treat other diagnoses, like if your patient has an abnormal EEG and you try to treat, maybe the patient has subclinical seizures, you have optimized anti-epileptic drugs, your EEG is not looking abnormal anymore, and you have to think about PSH. There is no other explanations. Like, again, it's a diagnosis of exclusion, and your patient has a history of brain injury. So this is a very interesting flowchart about how to assess your patient, and this is mostly for nursing care. But most of the time your nurse calls you when this is happening. So it's a good way of assessing your patient in an organized manner. So your patient most likely is going to be restless, agitated, having abnormal movements. Most of the time are decerebration. And you want to have at least one abnormal vital sign. Again, if you have more than one, it's even better. But you want at least one sign of either tachycardia that is acute and happen within 15 minutes of the posturing and the restlessness, or hypertension, again, within 15 minutes of that restlessness of agitation, tachypnea, or fever. And the heart rate, they describe greater than 120 or an increase from the baseline greater than 10 beats per minute, systolic greater than 160, or at least an acute change from baseline greater than 10, and tachypnea greater than 24, or change from baseline greater than 5, and the temperature, they always use 101.5. And obviously, you're going to culture your patient, but if you have all these symptoms and the restlessness, is most likely to be PSH. So if your patient, in addition to that, has sympathetic and clinical symptoms like pupillary dilatation, decreased level of consciousness, profuse diaphoresis, ventilator dysynchrony, or the dystonias, And then as a team, first of all, you say, yes, okay, my patient is storming. And what they did in this study is like in 24 hours, they basically did a detailed documentation of the timing of the syndrome, what triggered the syndrome, how long it lasted and the symptoms, and what did they do to treat it, and if it worked or didn't work. In 24 hours, they review the flow sheet and they identify triggers, what treatments the patient was responding to, and they started treating IV. They started with the intravenous medications and for 24 hours. And this is revealing what the patient responded to. For example, if you gave IV labetalol and the patient didn't improve, you're not going to use labetalol anymore.
Try one agent each time. So
They try one agent each time, exactly. And they always, the first line is opiates, because you want your patient not to receive that nauseous stimuli that will trigger that autonomic response. So they started with IV opiates and then benzodiazepines. At the end, they use antihypertensive, mostly beta blockers. They, at that time, with the 24 hours, they did the rule out infections, rule out seizures, maybe the patient got imaging, make sure it doesn't have a new structural lesion or hydrocephalus. And then 72 hours after the patient started to have all the symptoms, they analyzed those flow charts from the previous 72 hours and started oral medications based on what was working IV. For example, if your patient was responding very well to your fentanyl, or your fentanyl drip, like the case that we saw at the beginning, you will transition to oxycodone through the tube. And if your patient was responding very well to beta blockers, and it's mostly the heart rate what is disturbed and not the blood pressure, you can do propanolol. If your blood pressure is, your patient gets more hypertensive than tachycardic, then you can use labetalol and basically clonidine and so on. They also,
When it's the symptoms that's more deranged, and then use the medicine according to that. First line will always be opioids.
the first line is always opiates. Yeah.
If they do well with the opioids, do you test the other one as well?
Yes.
Okay. And then is there
Because-
a certain time window you have to wait between each one to make sure it's not the residual?
Well, the
opioid?
way they did it is abortive
Okay.
medications to know what is the mechanism that your patient was triggering. It was just that the opiate system was saying, hey, there is a lot of pain. You want to give the fentanyl and block that input into your brain.
I think,
If-
I think that she has like next time the patient having the same symptoms, would you still continue to give the opioids? Or would you like to try the other agents instead of opioids for the same symptoms?
In their case, they always try first line opiates. But it, again, we don't have a real,
Yeah.
and that would be awesome, developing a protocol, like you will try opiates and then
Yeah, I
you will
didn't
try
know
the
there
beta
was-
blocker. No,
Okay.
no, if the opiates helped, they will
That's it.
try opiates again.
Okay.
Yeah, and then for the oral, and the problem is that you don't want your patient to stop breathing if you give too much opiates. And you want to see if your patient wakes up and starts responding better to the stimuli. So that's when they try to see if the beta blocker also helps with the symptoms. And if they have good response, they will combine the beta blockers with the opiates or the beta blockers with the gabapentin. And yeah, actually, this study per se, the PSH assessment measure, this is still going. And I think they already have 10 centers. And when I was in Miami, we were going to be part of the study. And basically, in 24 hours, every single patient was going to be evaluated with this assessment measure. And these are hypothetical numbers, assuming our patient and you decided, hey, I think that this patient is storming. Let me look for my assessment measure, right? And you sat down and on the past 24 hours, you look for if the patient had a heart rate greater than 100, and then looking how high the heart rate went. And this is mild, this is moderate, and this is severe. And then you give points depending on how high the heart rate went in 24 hours or how high the respiratory rate went in 24 hours, or the blood pressure, temperature, sweating, and posturing during the episodes. And this is the clinical feature scale, right? After you get this number, you have an idea of how severe are the clinical features. Not only that they are present, but how severe they are. And with that number, right, you said this is very severe. And the likelihood tool, it's what we mentioned in this. When are you going to suspect it? Like your patient has risk factors. Is your patient behaving like an paroxysmal sympathetic hyperactivity? And you give 1 point for every single yes. Like he has more than one symptom, they are paroxysmal, and they may or may not subside with your treatment. It's been more than 3 days, it's been more than 2 weeks after the brain injury, etc. And at the end, you combine the clinical features with the likelihood tool, and then you say this unlikely, possible, or probable. And then, this is kind of a objective measure of trying to describe something so subjective at this point. And PSH is really abstract for most of the people, even after being described for almost 100 years.
So it looks like based on the scale, you could have a probable even without any of the risk factors. You could get threes on all of the top part.
Yes, because you will not expect,
All of that.
but think about it. If you have 3 on all of that, right,
Gotcha.
you already have simultaneously of
Okay.
symptoms, right? And maybe they are paroxysmal. And maybe your patient is having this for more than 3 days, so it's not mutually exclusive. And most of these questions will make you answer yes here, no matter what. And yeah, so it's not perfect. And we still don't know very well how to treat it. We still don't know if we should go all the way only with opiates, or if we should go all the way only with beta blockers. But this is the beginning of recognizing this very well-studied and under-recognized problem in this type of populations.
You use alpha-2 alphas to treat it.
The alpha-2, yes, we use clonidine. So treatments are gonna focus on 3 different mechanisms. You want to inhibit that afferent sensory processing, right? Saying like, this is painful no matter what. You want to inhibit the central sympathetic outflow, and you want to block your end organ responses to the sympathetic outflow. So if you target your voltage-gated calcium channels, like with gabapentin or your GABA B receptors and with baclofen, then you are targeting afferent spinal cord sensitization. So even if your spinal cord is saying a lot of things, you will say, no, calm down. We are not gonna let the sympathetic outflow to go crazy and cause all the symptoms. So even though we don't consider this first line, it's something that you should add on every single patient that you have high suspicion of sympathetic storming, and from the beginning. My experience is that this usually don't work acutely. like will not abort your symptoms, but it's gonna help your patient in a long run to wean off those opiates that you started that worked acutely and to avoid the symptoms per se. Can you talk to her about it? Hey, Mia. I'm good. I'm giving a conference to the residents. I'm gonna put Steven on. Yeah, I'm gonna put Steven on the phone. He knows the patient. Okay, thank you. So,
Baclofen better than gabapentin?
so they don't, they don't describe that any one of the treatments is better than others.
What do you like to try first?
Baclofen.
That's
Right.
like, I feel like
Why would you choose baclofen first?
Why is it so for the spasm of the gluteus?
Your patients most likely have
Because it's stony posture.
they have a spasticity already because they have white matter disease secondary to the brain injury, and they're having this tonic posture, so you would step back to help with that. But I feel like gabapentin in the long run is gonna help too.
Yeah,
It's not gonna
longer
be.
time for that to activate.
Yeah, so you suspected, you should target one of these, your calcium channels or your GABA B receptors. And then on top of that, we are gonna do some acute treatment, right? You don't want your patient to be storming for too long. You want to prevent the non-nauseous stimuli to provoke the storming episodes. So the GABA A, the dopamine and agonist, and the opioid receptor agonist are gonna help to prevent that sympathetic crazy outflow for every single stimuli that you give. And so in the meantime, while these are working, these are more acutely helping with the symptoms that your patient is developing. And we can use Ativan, Valium, Propofol, and that's why I don't believe in Propofol withdrawal. I believe like your patient is storming because you are decreasing your Propofol. It's kind of like a better understanding of Propofol withdrawal. You are basically removing that type of inhibitory effect and preventing the autonomic system to over react. And that's why you see all this posturing and all these symptoms every time you try to wean your patient from propofol. So a good alternative is that you give Valium or Ativan or Versed through the tube at the same time that you're trying to wean your patient off from propofol or from Versed drips. And then bromocriptine, like I usually don't like it because it has complications and some patients can get very confused and psychotic. And especially if you use it more than 7 days. But if your patient is having central fevers, usually breaks the fever right away. Bromocriptine.
Yes, same way. Fever. Are there any other things than fever for fever than you give? But this is only for central fever. The bromocriptine.
Exactly. Well,
Oh, the other that you were asking, we were discussing the same, just in general. Other things for
I think
that
just in general,
before, like,
yeah.
Patient, they could
Tylenol,
not give anything,
paracetamol,
Tylenol or
NSAIDs.
ibuprofen, NSAIDs because it was spiking, like blanket was not helping. So the other things can.
Yeah, it's gonna help with any
Even
type
if-
of fever. The thing is like, don't just give bromocriptine. You have to make sure your patient is not infected.
No.
If your patient is infected, you have to give the antibiotics with the bromocriptine. And then we have, in the old days, was morphine. Now we use mostly fentanyl drips. We try to stay away from methadone. Only if your patient has a history of IV drug abuse and was already on methadone, we will use it. We try to do oxycodone and more frequently, PO. And then you have your alpha and your beta, your alpha adrenergic agonists. and your beta blockers. And that basically are gonna act centrally and peripherally to ameliorate the sympathetic response if finally all those catecholamines get to those receptors. And that's when clonidine is gonna help you. Precedex is the continuous infusion of basically clonidine and an alpha-2 agonist. And propanolol. And again, I use propanolol or labetalol depending what is the main problem of my patient. If the main problem is tachycardia and the blood pressure is not such a problem, you can use propanolol. And but if your patient is mostly hypertensive, you will use labetalol. And this is a terrible chart that I don't think you can see at all. But basically describes the first line IV medications that has been studied in that assessment tool paper from 2014, which is the first paper trying to make homogeneous the nomenclature and the diagnosis and treatment for paroxysmal sympathetic hyperactivity. And they basically, they basically start with the labetalol again, and you can start with IV pushes, but eventually you can convert to your PO. Morphine, we now use mostly, but it's actually the slide.
Yeah.
I took the flash off.
Yeah, no, the
Oh,
slide
good,
is blurry
You can send
percent.
this to us right after this. right? I'll
Yes.
send it to you.
I will, yeah. No, and this one is gonna be uploaded in the webpage.
Okay, so fentanyl, now it's the most commonly used infusion for analgesia instead of morphine, but you can use morphine as well. It's the same mechanism of action. And then when you go to your oral or the second line agents per se, is when you can consider your propanolol, and they start with a dose of 40 milligrams every 12 hours. But if your patient is so hypotensive or his blood pressure is so labile, you can actually do 5Q6, 10Q4, 10Q6, so 10 TIV. And if that helps your patient and the symptoms, you don't have to go with the full 40 to 12. And you have the clonidine, gabapentin, and don't forget that gabapentin is renally dosing. We have had a couple of gabapentin intoxications lately in older people. And then oxycodone, and you will see actually the residents have noticed every time I try to wean my patients from continuous infusions, I always recommend to start oxycodone through the tube or Seroquel through the tube in order to have a better and more effective weaning without thinking that you are basically torturing your patient. It's still intubated and observation. And the bromocriptine, you can do 2.5 every 8 hours, but up to 7.5 I usually do the 5 TID. Okay, and then this is from another nursing paper that I found interesting, how they basically recognized the episodes and basically started with the gabapentin. They even use IV dantrolene, which is a very old medication, and we don't have it available in some hospitals. I don't think we have it available here. And some people actually say use the intrathecal baclofen for these patients that have very severe intractable spasticity and posturing. And they mentioned the non-pharmacological treatment, which is basically trying not to stimulate the patient, but sometimes it's impossible. You have to turn your patient on suction and make sure your patient has adequate nutrition and pain management. You can use cooling blankets if your patient is having fevers. And then they specify what is an abortive treatment, which I think is one of the questions that you ask, and what is a preventive treatment. And obviously abortive, mostly IV. You use your beta blockers, your benzodiazepines, and your opiates. And then they also mention clonidine. You can do the Precedex infusion or just clonidine. This is usually through the tube. Patients are usually are not taking pill. And for your prevention and long term for this patient that eventually you want to wean from the ventilator and send them to rehab, you will basically transition your IV medications to PO. And you can use any benzodiazepine, and oxycodone is actually my favorite opiate to use, and propranolol or labetalol. If your patient is very hypertensive, that's when you go to clonidine and bromocriptine if it's having central fevers. And if your patient is refractory to the abortive usual medications, you should keep your continuous infusions. And you should not just stop treatment and see what happens, because again, we go to the slide that maybe this is perpetuating secondary brain injury and the inflammatory cascade that the primary brain injury initiated, and that can translate in poor outcome, morbidity, mortality, longer hospital stays. And this is my last slide. Basically, I think everybody should read this, this paper if you want to have an idea of what PSH is. And this is the flow chart from the nursing journal. And this is the catecholamines study, which is interesting. They really don't explain much, but they mention all these observations of how the different brain injury pathophysiologies will even affect the paroxysmal sympathetic hyperactivity pathophysiology itself. Any questions? Was not too confusing?
So, let's say the patient is not in the unit, not intubated, and they call us from like step down because the patient is having sympathetic storm. So, do you want us to do the approach IV for 24 hours, see the requirements of the patient, and then transition to PO?
Is the idea, and it's actually what that paper suggests, that you should evaluate 24 to 72 hours with that flow chart.
Okay. And then adjust.
And notice which medications help. And in 72 hours, say, okay, this didn't work, this worked, and transition from IV into PO.
So who does the charting then? You have to give a nurses on board and give orders for all.
So,
So how does that
Ideally,
work?
ideally is your bedside nurse.
We just talk to them informally or?
this is another thing that probably like, we need to fill up another form. Maybe if we get a proper kind of, I don't know, like training of some sort. So we're thinking sympathetic storm, and then it's like a must. Like when we're doing a
24
2-cool
to 72
protocol.
hours, there's going to be call shift and the nurses are going to change. There's going to be
Oh, you guys are
some
done.
charting that we need to maintain.
I will tell you the last.
Let's replay.
Okay. So ideally, you want your